All right. Well, welcome everyone to our grand rounds for this beautiful day of May. I am really excited and honored to introduce our speaker today, Jennifer Freeman, PhD. She is a professor of research at the Brown Medical School in the Department of Psychiatry and Human Behavior, and she's the director of the Pediatric Anxiety Research Center at Bradley Hospital. Dr. Freeman, her work has beautiful breadth and depth. And I know this because I was very fortunate to be able to train with Jen as a postdoc and an early faculty member, and she has shaped so much of my thinking in my own research and my clinical care and how we think about integrating clinic and research to truly help kids. She has a very extensive history of mentoring and teaching. She's the child track coordinator at the Brown Clinical Psychology Internship Program. She's been very well funded from both the NIH and PCORI for her research, which has focused on assessment and treatment of OCD and anxiety disorders in children, which we're really excited to hear about today. She also has built amazing clinical programs that include novel outpatient programs, a partial hospital program for kids with OCD and anxiety. And she really centers community engagement in her work in a very meaningful way that I'm very excited to hear about today. And she did want me to note that most importantly, it was not very hard to get her to come here because she grew up in Minneapolis. She is a proud product of the Minneapolis public school system. And when I told her that I was moving here, she said that is the only acceptable place that you can move. So without further ado, Dr. Freeman.
Well, thank you so much. Christine, thank you all for being here. I need to undo something.
There's some stuff going on in the chat.
Are we good? Okay, I'm going to go ahead. Anyway, thank you. I'm so excited to be here. I'm so excited to get to talk to you. This has just been something I've been looking forward to for months. Seems like we're having a few technical difficulties, so we're just going to roll with that. Okay. This work that I'm talking about today is actually funded through a series of NIH and PCORI studies listed here, most of which are active, but some of which are older. But I have no conflicts with anything that's being presented today. So here's my quick nod to my Swiftie RAs. This is like the Jen Eras Minnesota tour here. I'm going to talk about the eras of our center over the course of this talk. But I was formed as a human by my parents. I guess I'm going to have two computers. This is weird. Anyway, so credit goes to my parents for raising me as the human that I am, but really the rest of the credit goes to Minneapolis and Minnesota. I spent my entire childhood here. I love snow. I love cold. People in Rhode Island make fun of me for like going running when it's below 30 degrees. I don't understand what the problem is. I have done every manner of everything around those lakes for my entire life. And that is my most happy place to come back to. That's me in the Boundary Waters, probably circa late 80s. I have run the Twin Cities Marathon. I know the Berkey is not technically in Minnesota, but I've done that too. I am a distance athlete, both in my real life and in my work life. And you'll sort of see that in what I'm going to talk about today. And the story that Christine has probably heard, I think Brian has heard, is that the real reason I'm a psychologist is because my failed perfect career as an ice cream bike driver around the lake. It didn't work. I thought that was the perfect job ever because I could be outside, I'd be getting exercise, there'd be ice cream. I crashed it on the first day of work near the Lake Harriet bandshell. It weighed 350 pounds and went running down a hill with me on the back of it, and the umbrella thing, like a sail. I crashed into someone's car. Nobody was hurt. The car was barely scratched. The person was very mean to me, and my mom bought all the ice cream. So thank you, Mom, because I think she's listening. So my other, and that opportunity led me to decide I think I need a different line of work. Camp Medlin in St. Paul and to what was then called the Washburn Child Guidance Center, which was a therapeutic preschool where I volunteered that summer, and then ultimately to St. Joseph's Home for Children, which is where I had my first job after college, doing a combination of clinical work and research, and that is what solidified my desire to be a psychologist and go on in this work. Okay, let's see if I can advance the slide. So I have a lot of objectives that I hope to get through today, but really I want to tell a story. I want to tell more of a narrative of our work. This is a story about the evolution of a clinical research center, about how research can help patients, and really authentic engagement with patients and others can help research, about opportunities that can come out of a need to pivot, which is really important right now, and the interconnection of research, training, patient needs, and innovation over time. So I hope I can do all of that. Okay, did I flip the slide? Make sure I didn't skip something. Nope. Okay, so our group, the Pediatric Anxiety Research Center, started in 1999. A little while ago, focused on testing treatments for children and their families struggling with OCD and anxiety disorders, with a real particular focus, especially at that time, on CBT and clinical trials. There were 3 of us at that time to start. I was one of them. And we have just celebrated our 25th anniversary, and there are now more than 45 of us. So we've gotten a lot bigger. And since that time, we've really, as Christine, we've expanded our clinical programs to include multiple partial hospital programs. We do the International OCD Foundation walk every year. This is a picture of a team, this is a few years old, but a team with families from our program. We have a family reunion that I'm going to talk about and show a little clip of that I hope the video and audio will all work. And along with our clinical evolution, we've really extended our research over these years beyond traditional clinical trials. That was our bread and butter at the beginning of my career, and is focused on increasing equitable access to exposure therapy through improved training, through service models to support exposure in practice, and through the use of technology that I'll talk a little bit about, especially to augment exposure. And we're really connected to our community, to partners that matter in terms of children's mental health. And that community engagement over time that has really grown quite naturally has transformed, quite honestly, our science and grounds the work that we do every day. So now all of our studies have some form of community engagement, a community advisory board, patients and families with lived experience. And I'm going to weave that in as I go through. The other thing to know about me in this park, in our center, because I am one of the oldest people there, I am known as the park mom to many people. I'm getting like active updates at the moment about someone who's in labor. And so if I seem distracted, I'm trying to figure out if one of my colleagues is having a baby. I am the park historian, and I'm also the park cheerleader. So. I'm also, I want to make clear, truly honored to represent like the very collaborative efforts of a team of researchers at PARC. Dr. Heron, Dr. Benito, and Dr. Kemp. The research that I'm going to talk about, particularly the last 12 years or so, represents the efforts of each of these amazing individuals and their own personal superpowers. And I am so lucky to get to work with them every day. Sad that Christine is not up here, but again, okay, because she came here. So I don't need to tell any of you in this room, demand for anxiety treatment is at an all-time high. It just keeps getting higher and higher. There's an alarming shortage of behavioral health care providers. And yet we know CBT is the most effective and appropriate treatment for youth with anxiety and OCD, especially exposure-containing CBT, with the largest, some of the largest, if not the largest effect sizes seen in all of intervention research over the last 40 years. So that's pretty impressive. And yet, even when kids are able to access CBT, many youth with anxiety and OCD, and I'm going to be talking about anxiety and OCD mostly throughout this talk. Many of these kids rarely receive exposure. Exposure training, low rates of comfort among providers. And so it's considered the, one of the largest research to practice gaps. I think you probably all know that, but I will say it anyway. So there are lots of solutions that I think we all need to think about collectively. And it's so fun to come to the lab meeting this morning and like start to think about these things together. Each of them are kind of their own moonshot as I'd like to think about it, but here are the things that I'm going to propose to you today. We need scalable training initiatives that are really capable of fitting the already of all of our existing clinicians, including many of us. We need novel service models that really effectively leverage all healthcare providers and teams of healthcare providers. We need to lean into emerging technology that can enhance quality while reducing burden to providers. And I will say with the caveat that we want technology with purpose and not technology for technology's sake. And I think that's a really important thing to think about. And then finally, we need strong community engagement. That maybe seems obvious, but we really want to ensure that what we're building fits the communities where we want communities, that there's uptake by communities that need it. Okay, so here's my fancy picture that I got help with from my friend, Dr. Kemp. This looks like a lot, but I want to really walk through the development of a line of research in our group that has led, from where we were in 1999 to where we are today. And I like to think of it as eras now that I've become a Swiftie. These are PARC eras. The primary focus throughout is going to be the development of our team-based service line, which is kind of the central line through the middle. But I'm going to try to sort of talk about both evolution on the clinical side of our work as well as on the research side and how these things are all intertwined. This picture is actually much more simple than what it looks like in my head. I've been drawing yellow pads, not in blue books for those who were at dinner last night, but and on whiteboards. And this is kind of the more simple version. Doesn't have other lines and boxes that I want it to have, mostly for simplicity's sake and because we don't have time to talk about all of it. And so especially we don't have time to talk about all the other research happening in our lab, especially the next study, which is in collaboration with the University of Minnesota, so the DMS project, as well as a number of other studies. So I just want to make clear this is just a subsample of what we're doing over there in Rhode Island. The other thing, and again, I think we've alluded to this, but I can't underestimate, is the power of all of our, in both our clinical work and our research work. I couldn't add this to my already complicated diagram, so I'm going to try to sort of, as I said, weave it in throughout. Our work with engagement and kind of thinking about how best to involve community members and patients and families really started in 2013 when we opened our partial program, and I'll talk more about that in a little bit. But it has expanded over time to include community agency leaders, patients and caregivers, sorry, that has a weird little Y's in the wrong place, and home-based providers. All of these groups have been added over time, in part along with some of our particular research studies, but all in the service of building out and advising on our work. And so all of these groups exist now. And like I said, are involved in different studies, but we tend to meet with each of these groups about twice a year and then have representatives from each separate group come together for a steering committee twice a year, where we can bring our results, bring our questions, bring our debacles, and get help from people with a lot of different ideas. And it's been amazing. And it's hard to imagine not having that piece. Okay, so now we're in era number 1. Think back to 1999, if you were alive. And I am going to summarize the first chapter really fast on this one slide. So this goes all the way to 2012. and Christine and Brianna both touched this era a little bit. So this trials, big NIH multi-site clinical trials. I came to Brown to work with Henrietta Leonard, a really famous child psychiatrist who we lost too early. And in these early studies joined the University of Pennsylvania and Duke, John March, Edna Foa, Marty Franklin, kind of like the greats of pediatric OCD, and got to work on these studies and eventually lead the Potts Jr. study. These were the first large randomized controlled trials to test CBT for kids with OCD. And there were a number of, and sort of include these follow-up iterations, partial responders, younger kids, but they were, what some people refer to kind of as horse races, just, studies to see which treatment works best. And they were all the rage back then. And we got to the end of those studies, and there was a clear need to disseminate exposure-based CBT. That was pretty convincing. And it was also a real time of growth for our group. We were rapidly expanding. We were growing our outpatient clinics. We were growing our studies and bringing on lots of new staff. So that was amazing. So now we're in 2013, and we're seeing not only do we need to disseminate this treatment, but there are real limitations of these RCTs. And by the way, NIH doesn't really want to fund big, large clinical, multi-site clinical trials anymore. So we need to come up with something different. And luckily, it was that, that was one of the reasons why we needed to pivot, but that wasn't the only reason. There were really clear needs, in our group to understand desires to understand who doesn't respond to clinical trials, who are the kids who don't get better. That's great. The 69, 70-ish% of kids are responders, but what does that really mean? And what about kids who are sicker, what patient treatment, who don't get included in treatment trials, for whom outpatient, treatment models don't work, and who need treatment in really contextually relevant places. So we wanted to take this really, evidence-based treatment that had come out of these OCD treatment trials and expand it much more broadly to anxiety and these other kids. And at the same time, our work that was really being led by, this side was being led by Dr. Kristen Benito at the time, was starting to explore treatment mechanism and asking, how exactly do you do exposure? These manuals of the time said do exposure, but it didn't tell you what that meant or how to do it, or exactly how you would titrate it, or what you say if someone says, no, or if a parent's accommodating in the session. So there was not a lot of instruction. And, I hope that we were doing okay because a lot of it was coming from wonderful supervision. But without that, there wasn't a lot of instruction in the treatments themselves. And we were also moving away from wanting everything to be so manualized and really wanting to focus more on the principles of treatment, which Christine was a huge part of, really leaning into thinking about function and the function of symptoms, and rather than the topography of one's illness. So Christine and I, mostly Christine, wrote a really cool paper way back in the day related to that. And it really changed how we trained people to think about what do symptoms look like? What does that mean? Is it just because something looks a certain way and someone says they have, contamination, or because they have washing rituals doesn't actually mean they have contamination obsessions? That's sort of how many of us were taught. And I always use the kind of school refusal example, like someone who is standing outside of school with a caregiver refusing to go in. There's often a quick assumption that topographically that child has separation anxiety because they're hanging on and not going in. But there are a host of things that could be going on for that kiddo. It could be separation anxiety. It could be GAD and they're worried about a test that day. It could be social anxiety and they're worried about talking to other people. It could be OCD and they're worried about a potential trigger that's a contaminant. It could be a lot of different things, and it's really, really important to think about that. So we were trying hard to think about how to improve training and quality, and it was really the beginning of starting to engage with families and providers in the community. So at that point, we branched in two different directions. The one direction is that we decided that we were going to grow an after-school partial program at this point, that we really wanted to make up this ideal program that would be a bigger dose of exposure every day, that would have individual treatment, family treatment, group treatment, social support, psychiatry, that there wouldn't be any inclusion and exclusion criteria, that we would accept all insurance because Bradley, this hospital, accepted all insurance. And so Bradley, for those of you who are not familiar with Providence in Rhode Island, it's actually the nation's oldest freestanding child psychiatric hospital. And the cool thing about it is that it only serves kids and youth. So everything, all child psychiatry of some stripe. And that makes it a very special place to do this kind of work, and a very accepting place to build a partial program, unlike the research building where we were before that, where we started testing this. And people were not as enthused about screaming kids in the hallways. So that was part of why we had to move. And again, we modeled it after some of the work that was being done at Rogers with bachelor's level staff, but really kind of thinking about training and quality and fidelity in our own special way. So the key innovation of this time was really to include bachelor's level staff as exposure coaches, again, in this partial setting, but to really be able to take care beyond the hospital. So when we made up this program, kids would come after school for 3 hours, and then they would have twice a week an exposure coach, a bachelor's level provider who got lots of training, go to their home or their school, usually not school, after school, but go out in the world and treat anxiety where it lived. And that turned out to be a really cool idea, and something that we were really excited about how well it worked, how much it meant to families, and the idea that BA level providers could really provide this very specialized evidence-based intervention. So expand the reach of kind of academic clinical specialists, straddle hospital and community settings, be financially sustainable with commercial and public payers, and that we could collect outcome data, kind of hit all the things that we wanted to be able to do. And simultaneously, we really, again, with Kristen at the helm, began developing a coding system on the full other end, to really understand exposure therapy process at the most micro level, coding every utterance that happens during an exposure session on video. So what therapist behaviors, relate to treatment outcome? How much time is spent on exposure? Are therapists, saying anxiety increasing or decreasing statements? How much accommodation is happening? We liken it to thinking about gas and brake, in a car. Is someone using too much gas, too much brake? One or the other is not good. We have to balance it. So how do you really measure the titration process? And the goal of this microanalytic and quite time-intensive coding system was to really understand the principles underpinning exposure therapy. How are they meaningful for understanding quality, for fidelity, and ultimately, how do they relate to the best methods for training therapists in community settings? And so that work really was sort of the underpinnings to what we were building on the clinical side. At the same time, I think I jumped the gun on talking about topography versus function, but that was all in the same era. So at the time, as NIH was moving away from clinical trials, there was also a really increased focus that has continued to this day in different iterations on treatment mechanism, which we found really interesting and really important, and the application in particular of experimental therapeutics models that had been mostly to that point before used in drug discovery, more in psychopharm research, to really kind of trying to hone in on these very, targeted processes. So that microanalytic coding work led to this new line of studies. And I've tried to include all the papers that kind of go with each slide as best I can. I'm happy to share any of those at any time. So in a series of studies led by Kristen Benito, which are a whole talk. This one slide is, is a whole talk. So I'm doing the highest level overview. But we adopted an experimental therapeutics framework to identify and test targeted implementation strategies. So study 1 really looked at the connection between therapist delivery behaviors, the middle box, and the treatment outcome box, and involved coding every POTS exposure tape. So those initial pediatric OCD treatment studies from 1999, all of those exposure sessions were coded, some by people who are in this room. And those results supported therapist behaviors as a quality indicator and as an implementation target. So that was good news. And we needed to figure, like, that was the first thing we needed to isolate. Studies 2 and 3 allowed us to develop a tool called the exposure guide, which I will get to in a little bit, that showed an initial signal for this tool or initial signal for the exposure guide as a training tool, first in a multiple baseline study, and then a second study that really confirmed it as an empirically supported implementation strategy in an RCT. So those 3 studies were very special and kind of changed our focus a little bit. Okay, I hope you're with me. It's now 2015, 2016. We're in this era of growth, and we are seeing on the clinical side that this afternoon program that we were so excited about, people coming after school, it was not enough. Kids were not going to school at all, and so they would be at home all day and then come to us at 3:30 or 2:30 and say, why aren't you in my room all day? And parents were frustrated and asking for more time. They were also asking for these exposure visits in the community and in the home to happen every day, telling us twice a week was not enough. Can't we do these visits 5 days a week? And so we wanted to think about how to expand the partial program. And we also wanted to think about how to expand some of these implementation and training studies to really, we were working in community settings with those studies I told you of Dr. Benito's, but we weren't really like expanding our reach and training as many therapists as we would have liked. So the next 2 steps were really to, I've sort of given away the punchline here, but to grow our partial program and to grow our training tools. So I talked about the development of the exposure guide. We took this very iterative development approach over time to develop this tool. I want to pause and just emphasize, because it's very important, that I certainly know, and we believe as a group, exposure is not for everybody. It needs to be tailored. It needs to make sense. It needs to be culturally and contextually responsive to a presenting problem. So this is not the answer. This exposure guide is not the answer to the entire, child anxiety crisis, but it is a tool that works well when it is appropriate. And so to test its usability and feasibility, we piloted this guide in our own clinics, in our own outpatient and partial programs, and with community-based therapists who are our intended end users. And the goal was to really ensure practical application, to make sure that we were prioritizing content that would really be helpful for improving therapist behavior. It was designed to be quick and practical, take about 5 minutes to complete after a session, and to really kind of reinforce key concepts. That was the hope. And it's worth noting that this goes along with the full training. We don't expect it to work in isolation. I'll talk more about that later. But here are 2 pages. There are 2 other pages that are not on this slide that kind of talk about troubleshooting and common reasons why there might be challenges and offer some ideas. But really the important things to notice are that behaviors are categorized by their function in relation to fear. So again, function, not topography. And there's a skip out at the top of the page that was added based on feedback from community partners. So that really aligns with our focus on making it as user-friendly as possible. And then the second part, and I promise I'll stop talking about complicated experimental therapeutic studies after this. Um, Even with improved training methods, we were still seeing lots of therapist reservations about exposure, about using exposure in practice, using exposure in the community. And we knew that was a well-documented barrier to uptake of exposure in community practice. And so at this point, this is now Dr. Kemp's study, the STRIVE study, really leaned into this idea that therapists' negative beliefs and avoidance of exposure mirror the same processes we see in patients with anxiety. So it's the idea of exposure to exposure, E to E. Um, um, text sounding. But this study was able to kind of isolate therapist beliefs as that mechanism and show that by doing experiential learning and partner learning and training folks to do exposure, that you could target therapist beliefs, make change, and see real differences in therapist delivery behavior. So that's super cool. And then the BRAVE study, which was Dr. Benito was the PI, was a study that, again, in a large group of community mental health settings, Christine was part of this too, trained 91 therapists in 6 different practices across community practices across Massachusetts, treating 177 patients, using the exposure guide as a training tool to really provide a full test of the exposure guide as this pragmatic quality measure. Um, and whether that plus training could really, again, change therapist behavior. So these studies were more focused on changing behavior, therapist behavior, than treatment outcome, which of course we care about, but that was more secondary in these studies. So I think that's an interesting thing just from a kind of a study design standpoint. They're different in that way. They're more around, they're more from a training and implementation lens and a quality monitoring lens. Okay. So, I showed you the front of Bradley Hospital before. I'm very literal. So the white building behind it is where we then got a chance to move. I'm going to guess 2015, 2016. You guys moved there temporarily. And so that building, the white building, was an old school. It had been a therapeutic day treatment school for many years, and that school moved off campus and was actually like multiplying itself. There are now many Bradley schools, and so we got the opportunity to move into this building, that building. It's not this building. I want to be in this building. This building is nicer than that building, but we were really excited to get to leave and have new space. And at this point, we were able to bring our entire center together in that building. We had been straddling 2 different campuses completely. And we were seeing really, really ill kids, which reminds me of the conversation that we had this morning. Kids that were being referred to us were just struggling in so many ways, and sort of on that precipice of do they need inpatient or residential, or could they be taken care of in a partial program? Kids that were not leaving their house, not leaving their bedroom, not going to school. We've had kids that can't walk on their own 2 feet for fear of something happening to a loved one, and have literally we had a teen who crawled into our program and left and actually joined the track team. So that is a big win. So this move to the new building meant we could add a 6-hour level of care, essentially a day program, a morning partial program, to really get at these kids who needed something more. And we were seeing a lot of comorbid trauma and mood dysregulation. We were seeing kids on the autism spectrum, lots of kids who had, untreated ADHD, and kids who are coming from really far away and, needing and staying either at a Ronald McDonald House or finding other ways to be able to stay, like in an extended stay hotel, to be able to stay with us. And we have grown since then, and now have a DBT exposure combined program for those really dysregulated kids that I'm not talking about today, but that also came out of a patient need. So as we were expanding, we needed to think even more about how to apply our own training tools and our own like desire on the research side to maintain quality and fidelity. How do we do this if we're hiring all these new people and we're expanding and we're growing? And so that was our kind of research clinical challenge at the time. And we also at that point had this very kind of beautiful, naturally grown parent advisory group that grew out of a group of families sitting in the waiting room of our space, which people used to do. Like sometimes caregivers of really, really anxious kids who were telling them do not leave. And so a lot of caregivers were stuck and they all found support with each other and community with each other that was really impressive. And they approached us and said, can we start a parent advisory group and give you guys some ideas? And we said, yes, of course. That was the right answer. And they started coming up, we started meeting regularly, and they asked for more community in the waiting room, which is where the walks came from. They asked for a residential program, which we have not managed to do yet, but we have on the list. They asked for more support for people who were coming from away and didn't necessarily live in our area. And one dad asked for a family reunion, like a college reunion. I think he called it a reunion. And we kind of looked askance at each other and we were like, well, I don't know, why would you do that? That's not really typical in a child psychiatric setting. But we listened. And because it is good to listen to your community partners. And so despite our initial misgivings, this family reunion has become an actual thing. It stayed a thing for like year after year after year after year. We've had, I think, 9 of them. I try to count. We lost a few to COVID. So we have people travel from like far away to come to these reunions. People have traveled across the country from Canada, from all manner of the West Coast, and hundreds and hundreds of families for this yearly event. Like it's poured horrible, awful weather, raining the past few years, and we've had more than 200 people attend. Even when we now have to cut the list based on like year, it's like college, like when you attended program. And it's kind of the most amazing day of the year in our center. I think kids and families are so excited to see each other. They're excited to see their staff, their doctors. We raise money to pay for it. Staff volunteer their time. I don't know of any other similar exact event. I mean, certainly in med specialties and ped specialties, it is common to have these kinds of reunions and really important. But I'm not so familiar with them as in psychiatric settings. And so it's really a testament, I think, to everybody who works in our program. It feels very positive, like in terms of fighting stigma and celebrating these kids and their journeys. And it engages our community and it's super fun. It's like a big party. We have food trucks and face painting and a photo booth. And we've had a band, like we've had kids from our program who have bands perform, which is a sight. Really awesome. And the food trucks are new. That's been kind of cool. So last year, it's my like personal cheerleader hat at the moment. I'm like really focused on getting this event onto the Today Show. If anyone has any connections or something like that, with our hospital communication folks. Maybe Natalie, where's Natalie? Maybe she can help me. So last year we made a video. I'm only going to show a tiny snippet because the video is longer than you need to see. And I'm not showing you this to see the talking head part, especially not the me talking head. I want to show it so that you can just have a sense of this celebration that I'm talking about and just see the happiness and the joy. Let's see. You here? Okay, turn it up.
Yeah. Reunion event is really incredible and one of a kind. It's very rare that families want to return to the psychiatric hospital they were treated at.
And I think it's a testament to the quality of care, the relationships that are built in the process of exposure, that we have patients and families come back and want to tell their providers all about their progress and tell other patients all about their progress.
To watch those reunions happen with one another, the like smiles on people's faces and how excited they are to come back here, that is incredibly special.
It's so energizing at reunion. And getting to see our kids and families getting to be themselves.
It's not an individual thing, it's a family thing, and it's a team affair.
We have so much gratitude too for these families. We get really close to the families and it's so nice to see them again.
And on graduation day, it's about living life, living exposure lifestyle. I want to hear about it.
Events like this are reducing the stigma associated with mental health. This is real. Because if you think about it, it's really simple. Our children are our future, and caring for them and reducing the challenges that they face are important for our families and for our nation.
There's much more of the video that I can show at a later point. I don't want to show it again. So I just wanted you to see a snippet of it because it makes me happy. The two kids in the shark costumes had planned that into the building in a pouring rainstorm in the giant shark costumes. And apropos our conversation at dinner last night, everybody who was featured in this video gave their permission. Special sticker showed that they're okay to be on the team. So back to research innovation. Now we're 2017, 2018, we're getting closer to now. Patients and families that were stepping down now from that more intensive partial program, but really from all of our programs, would often ask, as did this family advisory board, can I continue to have the exposure coach come to my house, even though I don't need to come to partial anymore? I don't need to come to your program for 6 hours a day. But when I have my outpatient visit, I want it to be one of those people, Terry, who you saw, who was also our DJ, or Tom, or Sue, or like these are all real people. I want them to be coming to my house to do this work where it really needs to happen, or at school. And that's what families wanted. And we didn't have an applicable billing code to make the service work at the outpatient level in the way that we were doing it, in a team-based way where there is supervision, where there is a licensed provider involved. And we wanted to make it available to all kids with all public and commercial insurance. And we didn't have outcome data about exactly whether that would work either, which was important to us wearing our research hat. And so, so we decided to write a PCORI grant for the first time that I'll talk about in a moment. That was my first stab at writing a PCORI grant. I'm so happy that we did. And this idea really fit with things that they were interested in funding. And at the same time, we were really starting to think again on the training side, how do we leverage the new technologies that exist? How do we bring ourselves into this century and really broaden access to some of our really time intensive trainings that we were doing in person for hours and hours and hours, and thought, you know, whether there would be asynchronous ways to perhaps do that more efficiently, as well as to make the super intensive microanalytic coding system that was taking, you know, 40 hours just to train someone to maybe be able to do reliably. Maybe we could make that more efficient and a little more practical too. And so you see on the bottom from an engagement side, it was in 2018 that we started adding a number more groups that were built as part of that first PCORI project. That's when we started adding the others. So kind of based on what we were seeing from these home visits in our partial program, I already said it, we were really convinced about the importance of treatment in real life context and the barriers that could be addressed by taking treatment outside of a hospital setting. And there were also really clear implications, especially on the outpatient side, for provider capacity. So, you know, we could treat many more kids. We could increase access. That felt really appealing. And just to be abundantly clear, we talked about this a little bit in the lab meeting this morning. The idea of team-based models was not new. Lots of community mental health settings for years and years have been using team-based models and non-licensed providers to be providing some of the service. but not always with a ton of training, not always using evidence-based practice, and often partnering sometimes our most junior clinicians, non-licensed clinicians, with some of our sickest kids that were stepping down from inpatient programs. So that was really hard. And then also there has been a lot of literature, especially in global mental health, for something called task sharing. So the idea of, partner-based work where a licensed and a non-licensed provider are working together. So that idea wasn't new, but again, those have often been more of a train the trainer model, as I said this morning, where the non-licensed provider is then becomes the only provider. There isn't that same monitoring of quality or supervision. So this slide is complicated and always is confusing, but this is our outpatient, what we call impact. So the impact study stands for Improving Access to Child Anxiety Treatment. And the model of care at the outpatient level for this team is that if you think of a 4-week month, of course, there are sometimes 5-week months, that repeats the exposure visit, but week 1 is in the office with a licensed provider. So in the case of the study I'm going to talk about next, with a licensed psychologist or a postdoc, and there is supervision with a non-licensed bachelor's level provider. And then the other weeks of the month, the exposure coach goes to the home or the community for a 60 to 90 minute outpatient visit and has supervision in the office with the same licensed psychologist who holds the case. So we use that phrase a lot. The licensed provider holds the case and is providing supervision as we would. And our exposure coaches complete all of the training that we have developed over time, a 12-hour, pretty intensive training. They do all the experiential learning. They get all the same didactic content as if we were going out in the community and training licensed therapists to do this treatment. And then there are special parts that are specific to working in a team and working outside of an office, and some shadowing that happens at least usually a minimum of 3 visits over time. And the folks that we have hired are people who've never done any clinical work or, certainly not exposure-based care and not independent. So this was our PCORI project. So we got the study in 2018. It was developed in concert with all of the partners that I showed you on that last slide, with really varying lived experience, varied content expertise, patients and families, people with a lot of expertise in home-based care. We really leaned on our ABA colleagues in the hospital who were very used to sending staff into the home and learned things from them, patient advocates, hospital leadership at our own hospital to try to really figure out how to make this work, and then also regional insurance providers. So to really work with payers from the start if the idea was to build a sustainable model of care. So we came up with this comparison of traditional outpatient versus this team-based model. And things were going really well. And then we had a pandemic, and that was unfortunately right in the middle of this study. So we had a COVID interruption. We did an open trial of telehealth that thankfully I got to talk a little bit about this morning with some folks. And so that I'm not talking about here today, but that came out of the need to pivot and continue to treat our kids, but turned into a really cool test of this team-based model via telehealth. I'll get back to that at the end. The other cool thing that happened before this study was even over was that we were able to contract with Blue Cross Blue Shield of Rhode Island, in part because I think we had engaged them from the very beginning, and they started paying for this service as an outpatient service in our own hospital clinic because they knew what a need there was, and they saw something seems to be working well enough, and that we did not seem to be causing harm. So they let us go. And okay, so these are really preliminary results. We have, the study ended up getting extended because of the pandemic. We rebooted in 2021 and had to finish the study and do all of the 3 and 6 month follow-up. So these results are from about 2 weeks ago. So they're really preliminary, and I don't have everything broken down in more detail like I would like it. But the thing to know, it's notable how many kids had OCD as the primary anxiety diagnosis and GAD. I think the GAD, there were, in my head, there were more kids with social anxiety and separation anxiety. I think a lot of that got lumped diagnostically into GAD. But the other thing to know is that this really was an effectiveness study. There were very few inclusion and exclusion criteria. Kids were really ill. So 69% were markedly ill on the CGI severity at baseline. 62% had more than 2 diagnoses. We included kids on the autism spectrum. 69% had had treatment in the past. Many were stepping down from our partial program, about a quarter. And 29% had had prior exposure. I think most of them were the ones stepping down from our partial program. And skewed a little younger than I thought, and was nowhere, it is not a very diverse sample in the way that I had hoped to be better than our past clinical trials. Interestingly, demographically, this matches Rhode Island as a state almost exactly, like to a T. It doesn't represent the most urban communities, Providence and Pawtucket and Central Falls, which may not mean anything to most of you, that we were hoping to overrepresent. And so that is something, again, that is a clear limitation. And this is the big deal of the week. So these are our intent to treat analyses. These kids did really well. And the thing to note is that the team-based group, what we call home, outperformed the office group at every time point, which we didn't expect. Now, outperformed, you can see they both did really, really, really well, but they did beyond well. I have pored over the data and actually called our statistician at 9:30 the night that we first got this. And I was like, I think it's a mistake. I think something's wrong. I'm not prone to panic, but I think maybe I was having a panic attack. And he was very sweet, and he walked me through it, and we went over it, and these are real. And so for this effectiveness sample, for this team-based condition to do as well as they did, we're beyond excited. And there's a ton to unpack that we don't have time to unpack today. What to make of it? I think, the bottom line is they got a lot of exposure. We used the exposure guide. We can see rates of exposure. Those are high, high across both groups, but higher in the home-based group. And attendance was a little higher, retention was a little higher, and they had an average number of sessions that was longer. Interestingly, and I'm happy to answer more questions about it later, treatment could go up to 6 months, but people could stop whenever they felt like they were done, or for any reason, of course. But so I was surprised that the average length of treatment isn't all that long, considering that they could go out to 6 months. So that was kind of interesting to me. I think the other two big pieces are the engagement piece and the training and ongoing quality monitoring. I think those were the two things that really kind of most, in my mind, probably contribute to these particular results. So shout out for a few quick last studies. This is a just recently completed project by my colleague Erin O'Connor using EMA and training parents to use the exposure guide to really do exposure in practice at home. And some preliminary results really suggest a lot of satisfaction and acceptability. This was just a tiny acceptability study. We have some other projects, again, that are trying to lean in on the technology side. So the ACE study is using existing data from coding, we like coding, of 6 trials to determine whether it's possible to train a machine learning algorithm to mirror that super intensive coding system. So that's happening now. And then the virtual reality project is an extension of that STRIVE study that I told you about, where taking those experiential learning strategies to use virtual reality to train therapists. Okay, so now I'm at the end. We're in the last era. We're where we are today. We're really trying to grow this model, both on the research side and grow our training so that we can really train the world to be able to do this and increase access for all. So I've talked a little bit about our collaboration with payers. I'm happy to answer more questions about that. I don't know how much to rush in the interest of time. So we are doing a lot of collaborating with payers at this point to build out our service model and have the tools from this impact study or the treatment from the impact study be covered by insurance routinely in our clinic. We're building, we just got an STTR grant, so a small business technology transfer grant to really start to build out, again, the sort of asynchronous version of some of these trainings, including our team-based trainings, so that we could expand access outside of our region and expand access to kind of the training and consultation tools as well. And then very lastly, this is kind of where my heart lies in addition to in Minnesota. This study is our new PCORI project that we got in November. It is the biggest grant that I have ever gotten. And it is, the goal is really to increase equitable access to high quality care for all kids and families in our state and our region by comparing treatment modalities. So kind of leaning into our team-based model, but comparing a telehealth version to an in-person version, which means treatment happening out in people's home and community, to a hybrid kind of flexible version, which kind of matches, I think, what a lot of us are doing in practice. And so this is a hybrid type 1, 5-year, $11 million project to study treatment modalities, like I just said, with a, in community mental health settings that serve a really high proportion of vulnerable youth in my state of Rhode Island. So given, really important questions, I think, that have grown out of COVID and COVID era about whether telehealth helps or hinders treatment outcome, especially in vulnerable kids, whether there's some data saying that it really doesn't, and there's some pretty striking demographic differences in terms of who does well with telehealth and who doesn't, but there's not a lot of data, and we really hope to be able to answer that. And we have this huge, robust network of partners, including now state government and policy partners, community health worker systems, and lots of other folks across the state to really help us think about how to build this. And so I end here because I really think about this study kind of as the culmination of all the work that I've talked many years, sort of building on our clinical work, our research work, training, quality monitoring, sort of taking all of our tools and all of these engagement partners and make amazing project that includes so many wonderful people with the hope of scaling it beyond Rhode Island. So look out, Minnesota. I'm coming here next, and I have good reason to want to come here. So it takes a huge village to make this happen. This slide is actually really the folks who've helped with our team-based work. I could have 10 other slides if I was really including slides for everybody that was on all of the other projects, but I know I don't have time to do that. It takes a huge team. We are a huge team: psychologists, psychiatrists, postdocs, trainees, research assistants, exposure coaches, all of our staff. Everybody contributes to the work that we do. So thank you. I'm there. I shouldn't have rushed so much. Okay.
So I help moderate.
I mean, what you want me to do.
Here, okay. Question. Start with in here and I'll talk to the people online.
So I'm curious, I know you said the hospital took all types of insurance. Did you see a difference in patients, like who was coming to the hospital in terms of private versus like Medicaid,
Yeah.
for example?
Yeah. So it's a great question. And there is a difference. Interestingly, there's sort of differences across different programs within the hospital. So the hospital in all of our, in all programs, but we see far fewer kids on using public insurance coming to our outpatient programs. And you can imagine much higher rates in programs where they're like inpatient program where there is less voluntary choice. So our hospital important to note, geographically, our hospital is East Providence, which is literally only about 7 to 10 minutes away from Providence. Will be like people consider Duluth closer here than people consider East Providence and Providence if you live there. So that's like a real Rhode Island geographic barrier to leaving one's community. And then there you add things like there's very poor public transportation in our state. So there's no really easy way. You have to take multiple buses and transfer downtown to be able to get from Providence to our hospital by bus. And then the major bridge that connects East Providence and Providence literally broke. So there are a lot of sort of structural, there are real reasons in terms of structural racism that I think that boundary exists, but like structurally the bridge broke, and that has led to that. So the reason for this new study, all of the work of the new PCORI project happens in the community health settings. We are training existing providers that work in those settings and have this care be available in everyone's community across the state. And so I hope that addresses that and answers that a little bit better.
Rhode Island don't.
Not at all. That was a real shock to me as a Minnesotan. I was like, you don't want to drive? Like when we moved our building, we literally moved like 7 minutes and people stopped coming to see me that had seen me in my old office because it was too far.
It was awesome. Thank you, Jen. I'm curious if you can talk about patients with eating challenges and how because we've had a handful of patients where that has gotten really complicated.
That's a great question. We see a lot of kids with, comorbid eating issues. So kind of fear-based ARFID kids seem to do the best in our treatment, programs where exposure makes sense, either, as part of their treatment. So we see a lot of those kids in our partial program as well as have been included in these outpatient trials. I think kids, who have true comorbid eating disorders and what's primary and what's really the target of treatment, I think those outcomes look different and are challenging. It's been challenging for our staff. We actually recently, a couple of our providers, we have one wonderful triple board psychiatrist in one of our programs who also works half-time in the adolescent eating disorders clinic. We have a psychologist who also works in that adolescent eating disorders clinic whose time is split between our program and their program. So the influx of the two of them, I think, has upped our game in terms of being able to really be super thoughtful about treating these kiddos. The thing about our hospital, even though it's wonderful that we are a full service child psychiatric hospital all in one place, it's not a medical hospital. And so we do not have the medical support that our colleagues at the Children's Hospital, that was close to where we used to be, have in terms of kids who really need monitoring or, sort of more intensive treatment. So kids who need that, there is the hospital, our psychiatry department operates a partial program that is probably a better fit for those kids, but doesn't do much. So I wish I had a better answer, except that I think those kids are complicated and a lot of them have done well. It sort of goes back to function, I guess. It's like, does exposure make sense as a treatment model? Not that we can't do, we of course, this is a very flexible principle-based treatment, very different than where we started 25 years ago. And so we certainly treat other things and include other things and weave in all manner of other treatments, but it's a primarily exposure-based treatment. So if that's not what someone needs, I would not include them.
We have a question from online from Sabina, who is a believer in vivo exposures. So she has a two-part question. So about the challenges with reimbursement and from payers for home visits. So speaking about that, and then billing ideas, and then any safety concerns about clinicians going into homes to do this.
Those are two things that we talk about a lot. So again, on the payer side, I spoke about this in Christine's lab meeting this morning, like lots of patience. This is where my like distance runner self has been important. Like these conversations with some of the payers have taken years, literal years, to get like payers to sign on to like, yes, we think this makes sense to pay for a licensed psychologist to be working alongside a non-licensed provider. And we've had success. So I mean, one of the things that was surprising to me that I don't think I fully appreciated is just how different, like just how different each commercial and um here would sort of think about this as a process. So we have really different agreements with different payers. And I think initially I was very focused on it needs to look exactly the same with every payer to be able to build something that will be sustainable nationwide. And I have had to flex on that and be more open to like doing it differently with different people. Again, coming up with a reimbursement model that works because that is required in our hospital setting. But what that means is sometimes it's billing more like at the individual. And again, this is getting into the nitty gritty of billing that we probably don't need to, but like sometimes it's more, in the way than an outpatient is more as a bundle and all of those things just sort of look different depending on what payer interest is, but it is doable. Like it's definitely a very doable thing. It's just more individualized by each payer than I would have expected. And some payers are, so our negotiations with Optum, for example, which runs United, that's at the nationwide level. So we've been talking to people like who, because that's how they do their contracting, which seems great. If we can make this work, then that will be nationwide. Blue Cross, which I would have totally assumed would have been the same for all Blue Crosses, not at all. So Blue Cross Blue Shield of Rhode Island is only Rhode Island. We've had wonderful success with them, but they can only like sort of put in a good name with us with other Blue Crosses as opposed to having that be larger. The safety question, super important. A lot of our training with our exposure coaches in that initial training phase is about safety procedures. We always have a backup system and not only the licensed provider assigned to the case, but a series of other folks on call in case anything is concerning while someone is on a home visit. And we do a lot of checks and work to make sure that the home is a safe setting to send a coach. And sometimes we do visits in outside places in the community if it seems like there are reasons why it doesn't make sense to go into a home. And there have been times where we have somebody arrive at a home and something doesn't feel okay, and that person has to leave or call one of us from the car, and those are hard. That's been not super frequent, but it's definitely real.
Do you record in-home visits?
Great question. We've really struggled with that over the years. For when they are research studies, we do. Obviously with consent, and these are families that have signed consent and can opt in or out of video and audio. I think in more recent eras, for again, when it's a study procedure, we have folks choose video or audio because we have to do that to be able to monitor the quality piece. Most people say yes. It's a little hard. It's like, I think people probably in this day and age have gotten much better at like, they're not using their phones. So, but like traveling from room to room, recording something, but so not the best quality, but we do. Not for partial unless there's some specific research context, yes.
It's kind of a follow-up question to that one. How do you bridge the gap between the exposure quality when you're working with the coaches in you train them to fidelity, but then you bridge that gap to adherence in the environments where you're not always there? How do you bridge that gap, and how important has that been to the insurers that are looking for the quality?
Yeah, it's a great question. I think that's one of the things that we probably struggle with the most is, how do you keep that fidelity in an ongoing way post-training with folks who have less overall training and these really complicated presentations of kids, and then you add the rest of like the family and the dog and like the siblings, and there's a lot going on. So we do have coaches use the exposure guide. They fill out the exposure guide after every session. We do that in our clinical service line as well as in our research service line, so that supervision still is really tied to what is happening with that exposure visit. We have a service line exposure coach. So outside of the research study, her name is Kadisha, and her rates of exposure are higher than what we see in our study. It's amazing. I don't know how she's doing it, but so that tool, in fact, has been really useful, and we've gotten people like to be, reliable, but more importantly, just to be using it regularly, and then that can be part of what is addressed in supervision. That seems to be working the best. And payers vary as to whether they like that outcome data. I was talking about a particular one of our Blue Cross partners who we've worked with for all along, and the one who really, I think, leveraged them wanting to pay for this, loves data and loves measures. So she has been really into that. Others seem less impressed. We shared the outcome data with a payer recently to be like, how are you not excited about this? And they were like, so I don't know. I think data is compelling.
Having been there like over 12 years ago and seeing the pictures of the same people, especially in the clinical setting, who were there then still there, like I've observed that you guys are very good at retention, and I assume that
Except for you two. Right.
helps with probably like the quality of the exposure too. Tom's gonna go in and do really good exposure. So I don't know if you could talk a little bit to how you foster an environment or like a pay structure, or how you keep people clinically so well that are doing jobs that are really challenging and don't typically get.
Great question. They still don't get paid super well. And again, that's somewhat out of our control. We argued a few years ago with the hospital. So the idea of a non-licensed provider in a psychiatric hospital setting has been a standard job for a long time with many different names in our hospital. U associate, behavioral health support staff, many other names. Anyway, we tried to argue that what our coaches do is different than what some of those positions are on the inpatient unit, in part because of the visits in the community and all of the intensive training that they have to go through and the use of quality monitoring tools. And that was actually successful. It was probably another 3-year argument. I am known for having many year arguments with a hospital administrator. The president of our hospital sees me and laughs and goes like this and goes running. So that is like the only place where my Minnesota nice goes away is in the context of those arguments. I'm nice about it, but so we were successful in kind of getting that. So it's like a specialized credential in some way within our hospital, and I think that has been meaningful for clinical staff and allowed us to have a little more wiggle room bumping up salaries, although still not like we don't have control to make that go much higher. I wish we did. I think for staff in our group, like especially for exposure coaches in our program, many of them, I was talking about Tom. Tom was someone who is the only person in our program who's probably older than me, is older than me. And he worked for 30 years in developmental disabilities in a group home, like mostly doing overnight shifts in a group home that was part of our hospital. So he's a long employee, but he on a whim was like, I'll apply for this job. And he was the very first person we hired, and he was excited to learn something new and learn a new treatment. And he is now the person who's had the most longevity as an exposure coach in our program. And as we've been able also to have different, like, so we have now exposure coach 1, exposure coach 2, and exposure coach 3 for a small number of senior coaches, again, to get at that, like, be able to have some upward mobility in terms of their being a supervisor. That has really helped as we've grown. I don't know what the answer to the rest of it is. I hope it's that we're a collaborative and kind and fun place to work. It doesn't work for everybody, and but we are a big family. Like, it is a big family. It's a relatively small building. Like, we're all sort of smushed together. That could be good or bad. We also have space issues, but I think for the most part, people legitimately like working together. We have not held on to everybody. We held on to a lot of people. I joke that it's not a cult. I promise.
For one more question, if there are any. Well, thank you so much, Jen.
Yeah, right.